nutrition in nutrition in critically ill patients. This is a very important point for discussion as most of our ICU patients either are malnourished or are undernutrited. And nutrition is one of the most neglected part in the ICU. So for this discussion, to discuss about critical care nutrition, we have an eminent speaker, a senior consultant and ICU in charge, Dr. Simant sir. He is from PSRA Hospital, New Delhi, and he will discuss about critically ill patients' nutrition. So, welcome Simant sir to this discussion, and uh, now I am over to Simant sir. Sir, please.
Thanks, Dr. Shrikant, for kind introduction. And I'm thankful to ICCM and especially Dr. Ranveer Tyagi sir for giving me this opportunity. Already has been talked a lot, nutrition. What we do, we generally ignore the nutritional status of the ICU patients. We give antibiotics, we give everything, but what we forget to take care of, that is nutrition. And you can see here, 38 to 78% and is independent associated with poor outcome. You don't treat, your patient is going to die. So basically, 1/3 of patients hospitalized in developed countries have some degree of malnutrition at the time of admission. If you properly assess the patient, 1/3 of patients admitted to the hospital without malnutrition. What you see, a trauma patient and other patient, you admit the patient, and sometimes you see the patient is going to be emaciated. Like we have got recently, we have got a GB syndrome patient. After 20 days of admission, patient was intubated, ventilated, and he was on tracheostomy tube. Because because the patient is not moving, no adequate, though we are trying to give him adequate feed and all everything, but he was emaciated. And at the same time, you have to see what comorbidities patient is having that can also lead to weight loss, like CKD, CLD, other things. These patients or the immunocompromised patients, if they are diabetic patients, they are admitted, definitely there is going to be a profound weight loss. So they lose around 2% of muscle protein per day, and critically ill obese patients become malnourished. That is obesity paradox. So what happens? Poor wound healing is there, and once there is a decreased immune function, chances of sepsis is there. And at the same time, if the muscle is not strong, you can see the patient is not able to breathe properly, and there is a decreased ventilatory drive and weakness complicating separation from the ventilator. The patient is on ventilator, you don't give adequate feed. Whether this is dysalkalitemia or other things, you will see the patient is having weakness and you are not able to take the patient out of the ventilator. That is weaning. Weaning cannot be done properly unless until your patient is given proper nutrition. And physiotherapy and mobilization, you don't do adequate physiotherapy and mobilization. You don't mobilize the patient. Even the ventilated patients, after some time, you can, if possible, patient is on tracheostomy tube, something like that, you can mobilize those patients. And sometimes this cardiomyopathy is also as a consequence of atrophy, is all related to the malnutrition. And the important thing is what we teach and what we do in our ICU, and everywhere it is being done. If you give enteral nutrition to prevent mucosal atrophy and diminish barrier function of the gut. And if you don't treat the patient properly, you don't feed him properly, don't give adequate nutrition, what happens? What happens? The duration of ICU stay is going to be prolonged, and at the same time, increase morbidity and mortality. These all you can see here, the total body composition, the water 60%, then fat 15%, and all protein 18%, the mineral you all know, total solids 40-60, and these all the things. There's circulating nutrients in the body, 75 gram hepatic glycogen, that is giving 300 kilocalorie. So in total, in storage, it is 1,65,900 kilocalorie in circulation, that is 1,13,000 kilocalorie. You can see the circulating fluid and all, how much 20 gram glucose, it gives around 80 kilocalorie. Post-operative, post-absorptive phase, what happens? The CNS and many other tissues, what they do, they use glucose, and that is a breakdown product of glycogen in post-absorptive phase. But you can see here the gluconeogenic phase. What happens? This is gluconeogenesis. This is glycogenolysis, the glycogen breakdown, the first one. Here what happens? Protein catabolism used to feed glucose to CNS, while other tissues are using ketones and fat. And again, this lipolysis and the ketogenesis phase, protein catabolism is decreased to a maximum. Minimum fatty acids are used everywhere, and ketones means fatty acids and ketones are used instead of glucose. That is only for the CNS. So it has been this is a rate of process, and here the starvation time it is being done here. This has been shown. So this is important slide. In days 1 to 2, acute phase, early period. Why this is important? Because you have to see how much nutrition you can give. Immediately your patient comes, you think the patient is cachectic malnutrition. You don't have to give 100% calorie in day 1 and 2. No. You have to wait. So that you have to see whether this is the acute phase. You have to categorize day 1 to 2, this is acute phase and early period, and the late period is from day 3 to day 7. Anabolism period is late phase rehabilitation and chronic phase more than 7 days. This is very important because you have to see how much calorie you have to provide. Starvation versus stress hypermetabolism, it has been compared here. And in hypermetabolism, gluconeogenesis is more, proteolysis is more, protein synthesis is more, and ureagenesis and other things are more. But in case of starvation, we all know the ketone formation, ketogenesis is more. Acute or chronic malnutrition plus comorbid stress, that is inadequate demand to, so nutritional risk is there. When the nutritional risk is there, what it happens? If the patient is not properly fed, not given adequate calories, your ICU length of stay is going to be increased. Ventilator, the patient is on ventilator, it is going to be increased. So all nutritional risks should not be ignored again and again, because stress and induced inflammation can lead to increased catabolism and reduced anabolism. Screening and assessment, we do screen the patients and who are at the risk of developing nutritional deficiencies. I told you before, even a patient of trauma and other things or any neurological cases, if not they are taken care of properly, they can lose weight in your ICU. If they are there for more than 10 days, 15 days, something. And at the same time, you have to assess the patient. What is the critical condition? What diet you are giving and other things, body composition and other things I'll talk about. So what is the problem with nutritional assessment in ICU patients? Parameters, what you have to see? Weight, that BMI you have to take care of, anthropometrics, albumin level, and what was before pre-albumin level. Accordingly, problem is that you are giving, patient is having edema, you are giving fluid, you are giving diuretics, patient is having infections. These are invalidation, inflammation, injury, and renal failure. So nutritional assessment, that is getting hindered. So we will talk in detail about all these things. And you have to think about the drainage tubes, wound, renal failure, and nitrogen balance is very, very important. It should be around 4 to 6 grams per kg per day. 4 to 6 grams per day. So, what ASPEN, that American Association one, that what guideline says, suggests not using traditional nutrition indicator or surrogate marker as they are not validated in critical care. So basically, this edema, fluid, diuretics, edema, these are not validated. What is written here? These are some basic nutritional screening tools like malnutrition universal screening tool must. NRS is very common. We were talking about NRS 2002, that nutritional risk screening, mini nutritional assessment, then short nutritional assessment questionnaire, then malnutrition screening tool, then your NUTRIC score, very frequently used. This NUTRIC score and nutritional risk system is very frequently used. And this subjective global assessment is also getting used. Now, this subjective global assessment of nutritional status, you can see a well-nourished patient, weight loss in previous, it will be around less than 5%. When it is categorized into the moderately malnourished, the weight loss is going to be between 5 to 10%, and severely, weight loss will be more than 10%. In well-nourished person, the dietary intake is good, more than 90% is required. In moderate one, 70 to 90%, and in severely malnourished one, less than 70% is required. So, muscle mass is going to be decreased in case of moderately malnourished, and the severely malnourished. Dependent edema is marked in severely malnourished, and ascites is also because of hypoalbuminemia. Albumin levels are low. Nutric score, I told you, this has to be, you have to remember, Nutric score, NRS score. What the variables are there in Nutric score? Is Apache 2, very commonly used, but this is cumbersome, this is used. SOFA scoring, number of comorbidities, and days from hospital to ICU admission. Then again, IL-6 levels that we're getting them very frequently in when we are having COVID. So less than 400 is 0, more than 401 is Apache 0, 1, 2, 3, this scoring, and more than 28 range when Apache is that the maximum score is 3. SOFA more than 10, the points are given 2, and number of more than 2 comorbidities 1. So again, Nutric score scoring system, if IL-6 is available, 6 to 10 is high score, and it is associated with worse clinical outcome. And if the patient is ventilated, mortality is more. These patients are more likely. Why this scoring has been done? Important thing for all your sisters and the staffs. Important thing, this score is meant for, you have to aggressively give the nutrition to the patient. Otherwise, there is going to be a mortality, the increased mortality. Low score means patient have a low malnutrition score. Again, if IL-6 are not available, again 5 to 9 is associated with worse clinical outcome, and 0 to 4, if less than 4, then there is a low malnutrition risk. This all scoring has been done to check how much feed you have to give. Then here again, this is NRS 2002 simple scoring. This 4 things you have to check. BMI less than 20.5. If the intake has been reduced during the last week, has been a recent weight loss, or is the patient severely ill, then again you check and again go all the mild score 1 and 2 and 3 accordingly. So it's a cumbersome one, and severity of illness accordingly that. And these are some diseases, mild score this, and the severe score 3, this head injury, the bone marrow transplant, other things. The detailed one. Initially, the 4 things you have to see. If the BMI is less than 20.5, then if your patient has intake is reduced, then again your recent weight loss. These all things. Then this is again you have to see all these things. What is new? American Society for Parenteral Enteral Nutrition, the variety of body composition. I'm not going to talk about this thing in detail. ESPN, basically European guideline. ESPN and ASPN is basically American one and Indian one. It has been compared. So all ICU patients should have nutritional risk assessment within 24 hours of admission. Then again, what ESPN says, American one, patient to the ICU, calculate both energy and protein requirements to determine the goals of nutritional therapy. Again, the Indian one also saying the same thing. Means your patient admitted, you have to check the nutritional status, to how much carbohydrate he needs, how much carbohydrate, protein, or the lipid the patient needs. Early or late. Within the first 48 hours of ICU stay, it is going to be early. Why 48 hours is important? Because initially you can see there is a hypercatabolic state. The protein and other things, everything is getting broken down. Then your gut integrity is compromised. Then chances of gut bacterial translocation and malnutrition and associated sepsis is there. And delayed nutrition produces the risk of refeeding syndrome. I will be talking in detail about this. This is a very important topic, refeeding syndrome. If you don't feed the patient and you overfeed the patient, what happens? We'll talk in the last. So pros and cons of the early this one. So what are the advantages? And so advantages are there. Maintain delivery of macro and micronutrients. Your gut flora is protected. Intestinal integrity is protected. It prevents refeeding syndrome. That is basically hypophosphatemia related problem, and treatment of any sort of underlying malnutrition. And enteral, this is basically enteral is safer than parenteral nutrition. We all know, and we will also talk about separately about the parenteral nutrition. What are the disadvantages and advantages? And what are the indications and the contraindications? What are the disadvantages of this enteral early nutrition? So poorly tolerance, chances of aspiration are there, and you know all the all the calories may not be utilized. No evidence that it prevents muscle catabolism. We never know how much calorie you give, how much feed you give, but still muscle catabolism and breakdown is going on. And together with the stress response, hyperglycemia still may result. So what are the evidences? evidence in support of early nutrition, no harm from early nutrition. And meta-analysis says decreased risk for infectious complications, you give feed early, enteral feed basically. When non-ICU patients were included, there is evidence that trophic feeding is beneficial. That is, early nutrition need not be targeting a full goal rate. What I told you before, whatever the calorie need is there, don't give 100% calories. Suppose the patient needs 2,000, give less calorie. That is trophic feeding, and it is beneficial. And what are the evidences against early nutrition? So none of the RCTs have ever demonstrated a mortality benefit from early nutrition. Many studies have demonstrated that hyperglycemia has a significant increased mortality and morbidity in ICU. So I'm not going to talk about those details. EGDN not appear to affect physical quality. So whatever the early centered randomized control outcome assessor blind, this is EAT ICU trial. So conclusion is EGDN, early goal directed nutrition, does not appear to affect physical quality of life at 6 months or other important outcomes. So it is basically inconclusive. Again, if oral intake is not possible, early enteral nutrition should be initiated within 48 hours. Spain and Indian ones, all are telling the same things. Whatever guideline is coming, don't give oral, enteral should be started, put the NG tube and start feeding. Enteral versus parenteral nutrition, you all know, contraindications, reduces intensity of SIRS if you give enteral nutrition, preserve gut mucosal, I talked before, and more balanced composition of amino acids is also going to provide you trace elements and minerals. What are the contraindications? When you could not put the NG tube, there is esophageal trauma or tumor or something, anything. There is some obstruction in the esophagus, or there is ischemia, gut is damaged. Then you don't have any surgery has been done. You cannot put those things, surgery on stomach or the lower down. So that cases or interrupted gut is there, and too fast transit time is an infectious diarrhea. Then you give TPN. Again, calories trial, route of early nutrition support in critically ill patient. So I'm not going to talk about what the guideline is saying. Oral diets shall prefer over internal or PN. First, you give oral diet. You all know. Start oral, not possible. Give enteral. That's all. Whatever these guidelines you're saying. And in case of contraindication, oral in EN, PN within 3 to 7 days. When you cannot give, your patient is having vomiting and other things, not tolerating enteral, even though not the oral or internal, then you don't have any option. Start your parenteral nutrition. If the gut works, use it. If you do not use it, lose it. So bowel sounds only gives you that there's a passage of air. So bowel sound is there. You cannot start feeding. Nothing like that. So normal myoelectrical activity returns to a small intestine. The problem lies in colonic recovery because it takes longer time, 3 to 5 days. So colonic recovery hastens when stimulated by enteral feed. So gastrointestinal, myoelectric, and clinical patterns of recovery after laparotomy. This has been discussed in this journal. So again, hemodynamic instability and enteral nutrition. So these are the trials and everything has been done. So we'll talk about the guidelines. What are the guidelines says? So this is NR. This is not applicable. Then non-occlusive eccentric ischemia. All the trials they are telling about what they are telling about. So in case of when your hemodynamic instability there, hold your enteral nutrition. We will talking about this guideline. So what your guideline says? Spain and the CCM. This is important one. We suggest that in the setting hemodynamic compromise and instability, EN should be withheld until the patient is fully resuscitated or stable. This is the important thing. When the patient is on high vasopressor support, this guideline says 2016, you should hold your enteral nutrition because the gut is not getting that much blood and absorption will be slow. So there will be status of the feed. Absorption is going to be hampered. So surviving sepsis guideline, the same thing against the administration of early, but it says you don't have to give parenteral nutrition, but rather it is a early nutrition. Antiseptic shock who can feed enterally, you can give enteral. It has got strong recommendation with moderate quality evidence. Again, SPEN guideline 2018 in patients with septic shock receiving vasopressor inotropes, no evidence-based answer can be proposed as no intervention studies have been. Though this is something what nothing can be done. whether you can give enteral or not when the patients are vasopressors. But the one guideline, 2016 Aspen guideline says, or SCCM on that one, 2016 surviving sepsis guideline, you hold your feed. Don't give parenteral, don't give enteral nutrition when the patient is on very high vasopressor. So intermittent and bolus methods of feeding in critical care, it has been tried. So basically, continuously bolus patient will tolerate, but the better the patient is going to tolerate, the continuous feeding in critically patient to be initiated at the rate of, this is going to be more tolerated, 10 to 20 ml per hour accordingly. What your guideline says, continuous rather than bolus EN. Even the Aspen guideline says intolerant to bolus EN should be continuous, and this Indian guideline, the same thing. Again, gastric, duodenum, and jejunum, whatever the gastric one will cause, chances of aspiration is there. Duodenum, chances of aspiration is less. In jejunum, less. But duodenum and GI intolerance required, because you cannot put that in duodenum, you require fluoroscopy, endoscopic placement, and other things, unable to use to aspirate to see tolerance. So it has got disadvantage, other things. So what are the indications? Normal gastric emptying, you can put gastric. Otherwise, impaired gastric emptying at the risk of aspiration, inability to tolerate gastric feeding, those cases you can put these ones. The SPEN guidelines, gastric access as the standard approach, post-palliative feeding, initiate internal in the stomach, NG route the first choice, if the chances jejunal route can be used if required. So first thing, put in the stomach, otherwise then there's duodenum or jejunum later. Other guidelines say the same things. When to start parenteral, any disorder in which enteral feeding is not an option and the prolonged bowel rest is needed, there is a gastrointestinal fistula, there is a bowel obstruction or ileus there, you have to start the, or short bowel syndrome with malabsorption, or patient is vomiting like anything, you cannot give enteral, you have to start the parenteral nutrition. When to initiate parenteral nutrition, assess risk of nutritional depletion, NRS score we have talked before, if it is the nutritional risk score less than 3, then start TPN after 7 days. When still the patient low risk of well-nourished or well-nourished patient then. And if it is NRS score is more than 5, early TPN as possible with 80% total calculated. Don't 100% calorie don't have to give. Then again, patients on enteral feed inadequate, then add TPN after that 7 days. Then patient on PN undernourished, continue on TPN. The patient is on parenteral nutrition, you don't have to stop, you have to continue. So concept of hypocaloric feed, I'm not going to talk. So hypocaloric feed, they have discussed what it is. When delivering less non-protein nutrients than they are required, less calorie you are giving. Caloric feed, I'm talking for less than 500 kilocalorie, maintaining integrity of GI tract, not nutrition. So trophic feed, less feed, permitting underfeeding, then trophic feeding. So rationale for hypocaloric nutrition, no method is 100% accurate to predict requirement. The theoretical immunological advantage to hypocaloric can be, the caloric needs are lower than energy expenditure. I'm not going to talk about details. So early phase, a few hours up to 3 to 7 days, anorexia, limited energy expenditure, and this all things. You can see here the caloric date is there. When you give feed, but this is caloric intake is not that sufficient. But in the last, you can see the caloric date is less feed is being given, then it is increased. Energy expenditure is here less. When overfeeding, you start from day 1. So last, you can see the last one in the time with the time goes by, is up to 6-7 days. This energy expenditure is more when the patient is overfed. So what is overfeeding, autophagy, refeeding? I'm not going to talk about all these slides, parenteral nutrition and other things. So activators of autophagy is fasting, cellular stress, and hypoxia. And the reverse is when you give nutrients, you give growth factors, you give insulin, that suppresses your autophagy. Because autophagy can, what autophagosome, it is being prevented. So nutrition may not prevent muscle breakdown. If you give how much nutrition, you can see in the body, even if you cannot have body like this. If the patient is have muscle breakdown, you cannot stop, even if whatever feed you give. So inflammation plus hypercatabolic state is used for muscle breakdown. Beyond a certain point, aggressive nutritional support may promote fat gain instead of preventing muscle loss. So what are the evidences? I'm not, so normocaloric versus hypocaloric feeding on the outcomes by systemic review and meta-analysis. So I'm not going to talk about all these things. So meta-analysis failed to demonstrate whether you give normocaloric or the hypocaloric, there is no difference in the ICU during the acute phase of their illnesses. So permissive underfeeding or standard enteral feeding in high and low risk critically ill patient, No differences. Again, this post hoc analysis of permit trial. Again, guidelines, the isocaloric nutrition can be progressively implemented after the early phase of gives low feed with isocaloric, or if predictive equations are used, hypocaloric nutrition should be preferred over that. Equations I'm not going to talk about. Isocaloric nutrition after this. Again, then Aspen criteria in obese regimen should not exceed. Initially, in every trial, whatever you see, you give less feed, target around 65 to 70%, and the weight based is now 11 to 14 kilocalorie per actual body weight per day for the patients with BMI in the range of BMI is more than 30 to 50 or 22 to 25 kilocalorie. And again, intentional underfeeding can be restricted to specific indications. So internal formula, this is a standard polymeric formula. You can see intact proteins, complex carbs, and this one LCTs, other things. So this normal digestion and absorption process is needed, available with different elemental one. I'm not going to individual amino acids, low in fats, especially SATs, then long chain triglyceride. Basically, this is minimal digestive function needed. Semi-elementals, protein that are hydrolyzed and specified when we have patient having liver failure, kidney failure, other things. So these things I'm not going to tolerate. So what guidelines says? Guidelines says standard polymeric formula, avoiding routine use of all specific. Don't use that specific formula in critically patient in ICU and disease specific formula in the SICU. So standard, no routine use of specific formula, closed system ready to hang formula fits preferred. Don't use that specific formula and the powders and other things. You can see what is the content of the milk, toned one 350 ml, how much calorie, 500 kilocalorie, then 23 gram of protein, 18 gram of fat, other things, diabetic feed, other things. These are the slides here. So proteins, how much protein you have to give? Spain, that American one, European one, Indian one, they all are between 1.3 to 2 kg per kg of body weight. So there is no controversy here. Again, amount of glucose required should not exceed more than 5 mg per kg per minute, and the lipid not exceed 1.5 gram per lipid per kg as part of parenteral nutrition.
Sir, sorry to interrupt. There is some question, sir, from Sweetie Minch.
Yeah.
Can we take that question now, sir, or
just let me finish, then we'll lastly I'll finishing fast. Okay.
Okay. Thank you, sir. We'll take the question at the end of the class.
Okay. Indian 2000 again, that we know that 25 to 30 kilocalorie per kg of body weight can be given. So in severely hypercatabolic patients such as extensive burn and trauma, and ratio of kilocalorie nitrogen should be 120 to 1 or even 100 has been accepted. So immunonutrition, it has got a value, includes your arginine, glutamine, but you should not, I'll talk about glutamine, omega-3 fatty acid, EPA, alpha-linoleic acid, antioxidants you can give in every situation, and the probiotics. These are immunonutritions. So benefits, disease modulating nutrients are there. They attenuate metabolic responses and they prevent oxidation and modulate immune responses, and probiotics are good for your gut environment. So these all criteria spin all. So ICU patients, additional internal glutamine should not be administered. What we are doing, we give glutamine. The pharma people are coming, we give glutamine. No. Except burn and trauma patients, you don't give glutamine. In unstable and complex ICU patients, particularly those suffering from liver failure. Remember, patient having renal failure, liver failure, kidney failure, don't give glutamine IV. Supplemental internal glutamine not be added to EN regimen routinely. You should be giving only when the patient is having traumatic brain injury and perioperative patient in SICU, you can give. Glutamine not recommended in critically ill patients with multiple organ failure. This is Indian guideline 2018. So I'm not going to discuss all these things. So again, internal enriched with omega-3 fatty acid doses can be administered. So high doses omega-3 again should not be given on routine basis. You choose the patient properly. Parenteral lipid emulsion plus enriched with EPA, DHA can be provided patient receiving parenteral nutrition. Immune modulated internal formulas, all these things should not be used routinely in the ICU. Arginine immune modulated formulations and icosapent pentanoic acid, all these things supplement with the standard interformula. We have only in traumatic brain injury patients you can use these patients. So ICU patients, they are the glutamine adequate data. So glutamine, no. Only in trauma and burn you can see here. Arginine, no. Antioxidant in all cases, ICU, severe sepsis, ARDS, you can give. Combination immune, they are debatable. So micronutrients should be provided daily with polluted, that is okay. Antioxidant in high dose administered without proven efficiency, but this is not harmful also. So combination of antioxidant, vitamins and trace minerals doses to those patients who require specialized nutritional therapy. Micronutrients can be supplemented in patients on blended feeds and those. So these are things you have to choose your patient very judiciously. Disease specific, I am coming about the renal patients standard internal formulation. If significant electrolyte abnormality develops, specific formula feed, and especially the patient on CRRT, continuous renal replacement therapy and hemodialysis, don't be shy. Only 1 gram. What we do, 1 gram, 1.5 gram, give up to 2.5 gram per kg per. Do not restrict proteins. Strictly, it has been written here. Patient receiving frequent hemodialysis or CRT receive increased protein up to 2.5 gram. So all guidelines are in favor of this. Protein should not be restricted to Indian guidelines. So you should be keeping this respiratory, high lipid and low carbohydrate not recommended. If the patient is having COPD and other things. And consider fluid restricted calorie dense formula. This is important. Fluid restricted calorie dense formula. Close monitoring of serum phosphate. We'll talk. Trophic or full nutrition. EN is appropriate to patient with ARDS. And when the patient is having acute lung injury or patient is mechanically ventilated for more than. So trophic low doses, then you can slowly increase your doses. And this all in Indian guidelines says small frequent feeds, especially high fat, low carbohydrate. If not, again, high fat, low carbohydrate, no. So acute pancreatitis, fast for first 3 to 4 days, advance to normal oral diet before 72 hours if the patient can tolerate. No need to rush for internal nutrition. Patient cannot tolerate oral diet, then internal nutrition, and avoid TPN as far as possible. So the trial says, this trial is telling early nasogastric in nasointuitive feeding as compared to oral diet after in reducing the rate of infection or death with acute pancreatitis are high risk complications. So this is all are in favor of when you try to give oral, then if not possible, then enteral. So EN is preferred, enteral is preferred to parenteral nutrition, both aspirin and ESPN. Early enteral nutrition, we all know. And what are the, as usual, 25 to 35 kilocalorie per kg per day. The protein should be 1.2 to 1.5 gram per kg of protein. Carbohydrate, you remember here, 3 to 6 gram per kg of carbohydrate, and go easy on the lipids. Lipids should be around up to 2 gram per kg, not more than that. When to, if the EN is simple thing is, if the internal nutrition is not is contraindicated, then only a parenteral. So nasogastric feeding is safe and well tolerated with nasogenital feeding. Even the nasogastric we're talking about, if the chances of aspiration are there definitely, but this is safe. Critically ill sepsis patients, EN feeding as tolerated within first 48 hours of diagnosis. Avoid mandatory full calorie feeding in the first week. Advancing means slowly you increase your feed. I'm talking to all staff. Don't give this much calorie. Suppose you want 2000 calories. Don't give that much. Start with the 1500 calories. Give slow feed. Then if the patient tolerates, then start increasing. So no special immunomodulation supplements critically ill septic patient. Supplement the TPN only if you are not going to meet your calorie requirement even after 1 week. Then this is basically surviving sepsis guideline. The new guideline also, everything same. Start oral, enteral, then you parenteral. So feed delivery, you can see. Then you GI is glycemia index and GL is. So continuous feeding should be preferred over bolus feeding in this glycemic patient. Continuous feeding is advocated, not bolus feedings. Low dose. Glycemia targeted specialized nutrition should be identified with low GI, low glycemic and low GL rather than individual carbohydrate ingredients. Look for the GI and GL. GI and GL important parameter with regards to feeds for this glycemic patients. Liver, when the CLD patients and all. So what we do, we don't restrict protein. Give 1.5 to 2 gram of protein or 1 to 1.5 and branch chain amino acid for refractory. The patient is having chronic encephalopathy, patient is not coming out. Then you try this. A standard enteral formulation can be used in ICU with acute, and that's all. And no evidence of further branch chain amino acid, no further evidence, but can be used in case of chronic encephalopathy. Whole protein formula providing 35 to 40 kilocalorie per kg of body weight, and energy intake and 1.2 to 1.5 gram per kg body weight per day protein is recommended. But in renal patients, When on the CRRT, even up to 2.5 gram per kg. When the patient is having neurotrauma, so resting energy expenditure, RE is increased by 100 to 100 patient, non-paralyzed patient with severe TBI. So energy expenditure is very high. So early enteral feeding with a high protein per diet is advocated in first 24 to 48 hours, because you will see the patient losing weight after 4 to 12 days post-op. You don't provide adequate feed, your patient is going to be cachectic. So how much of the daily carb? 25 to 35 kilocalorie per kg per day of carb, and 1.2 to 2 gram per kg per day of protein. Burns internal first choice. Parenteral resolve only when internal is not tolerated. This is the simple funda. Parenteral only when internal is not tolerated, patient is not getting adequate caloric needs. And proteins 1.5 to 2 gram per kg per day, and early initiation of internal nutrition everywhere. Obesity, then you have something here, insulin resistance and impaired glucose tolerance, increased fatty acid mobilization, hypertension. I'm not going to talk about all these things. Auspin recommended high protein, hypocaloric feeding. Start with the low dose, 60 to 70% of calculated energy, always and everywhere. And 2 to 2.5 gram of protein, ideal body weight, and 1.3 to 1.5 kg of actual body weight. So what are the barriers in morbid obesity patients? Difficulty in calculating nutritional goals. This is the first barrier. Poor feed tolerance because the gastric emptying is slowed. Difficulty in meeting the high protein with internal nutrition. That's why you switch to the parenteral nutrition. And problems with calculating appropriate protein and carbohydrate. How much carbohydrate and how much protein you have. And you have to minimize muscle catabolism. At the same time, don't give overfeed or the parenteral nutrition, because already this patient is having metabolic syndrome. They can be having hyperglycemia, and again it will be difficult to control. So coming to the oncology patients, you all know that is having poor prognostic factors, increased toxicity of chemotherapy, increased response to therapy, then increased unplanned hospitalization. We never know when the patient will increase length of hospital stay and increased morbidity, mortality. So what is here? Alpha-linoleic acid, icosapentaen, and docosahexaenic acid. In conclusion, omega-6, this is PGE2, prostaglandin E2, and leukotriene B4, reduces the level of what did this happen? So omega-5 favors PGE3 LT5. So what omega, so PGE3 LT5, it reduces the level of PGE2 and LTB4. So this promotes PGE3 LTP better than your omega-6 fatty acids, hence improved immunocompetence and reduced inflammatory responses. Again, total parenteral nutrition, ensure adequate central venous access, because either subclavian, because the chances of infection very less. Don't use your femoral, chances of infection there much more. And subclavian, easily tolerated, and dedicated lumen for TPM. And when more than 2 months, permacath has something considered tunnel line, so that the more than not this central line. Tunnel line are being used like your permacath, other things, tunnel tip, this one, catheters are there. And what you have to do, every 12 hours, you have to assess for the enteral feed. You have to check like your central line, whether there's a blockade or something, you have to flush it. Don't forget flushing your feeding tubes, whatever the lines you have put. Again, energy, how much? 25 to 30 kilocalorie per day, non-protein kilocalories. Dextrose, 3.4 kilocalorie per gram. Lipid emulsion, 9 kilocalorie per gram. I'm not going to talk about this. That is maximum up to 1.1 to 1.3 gram per kg per day. And water, 30-35 ml per kg, or 100 to 50-20 ml per kg. First 10 kg, then next 10 kg, and rest you have to increase the water intake, because you never know, all the septic patients, they are having some bowel volume overload, kidney is not working properly. So immediately don't overload your patient. Slightly increase. Sodium 1 to 2 ml per kg per day. Potassium 0.7 to 1 to 2 millimole per kg per day. Calcium, phosphate, this is written here, 10 millimole. Phosphorus is very important. Vitamins interest not defined. So volume, when you internal vein, central vein, always more calories you can give. You can give more nitrogen. You can give more sodium and other things. So prefer putting central line, but maximum infusion rate is more with the, as per the Postul's law. Through your, if you 16 gauge or 14 gauge cannula, peripheral cannula you put. So parenteral calculation of daily requirement, how much daily requirement of parenteral nutrition? So bag should be about 2 liter, 70-30 liters of carbohydrate, protein around 1.5 to 2 gram per kg per day. Fat is supplied 10% limitable impulsions and 1.1 kilocalorie per ml. Carbohydrate, I'm not going to talk about all those calculations. You have to calculate TPN and dextrose 1400 kilocalorie, lipid 600 kilocalorie, not more than that. And using 10% lipid and protein, as usual, 1.5 to 2 gram per kg per day. Water requirement 30 to 35 ml per kg, around 2 liter in a roughly 65 kg patient. And available bag will deliver around 80% by carbohydrate 50%. So 50-50 carbohydrate, lipid, and protein delivered around 1 to 1.5 gram per kg per day. So not so. So monitoring water tumor site of vascular access, don't forget there could be sepsis, there could be blockade. Blood sugar has to be monitored when the patient is on parenteral nutrition, your daily KFT and your LFT especially, and the triglyceride level has to be monitored. Complications, it could be catheter-related thrombophlebitis, insertion-related blood stream infection can be there, and metabolic, your high blood sugars, or even the low blood sugars, electrolyte imbalances, the refeeding syndrome we'll talk in detail, hepatic dysfunction, acalculous, and increased triglyceride level, and could be fluid overload. The patient is having renal failure, other things, and azotemia. Weaning from TPN, again, don't put the patient on TPN. You have to come back to the oral or enteral. You cannot give TPN for a long time because it has got its own complications. So EN troubleshooting, high gastric residuals, when you have put water troubleshooting, when you should think about diarrhea is there, constipation is there, refeeding syndrome or the dumping syndrome, immediate gastric emptying is there, unable to reach your calorie requirement, metabolic complications are there. So prokinetics can be used, erythromycin or metoclopramide, all American, European or Indian guideline, they are telling that they can be used. So ASPEN, monitor daily for tolerance of enteral nutrition. What you'll do, NPU for the patient surrounding the time of diagnostic test, and gastric residual volume not be used as a part of routine care. So up to 500 ml is cut off. Both Indian guidelines, Indian guidelines say 300 500. So high GRB symptoms, vomiting, regurgitation, more than at least one visit, then diarrhea, loose or liquid stool, then bowel distension, then GI bleeding, intra-abdominal hypertension, we know more than 12, so grading is there, grade 1, grade 2, grade 3, abdominal compartment syndrome we tell when the pressure is more than 20, with new organ dysfunction failure, with intra-abdominal pressures measured in supine position. So these things, so diarrhea, how to prevent diarrhea? The important thing for all staff, diarrhea is there. The enteral nutrition not be automatically interrupted. You don't have to stop it. You have to check what is being given. Fixed fiber consolidation, there is evidence of persistent diarrhea and other things. And fiber formula you have to check. So nutrition, so might be overdose of hyperosmotic drugs, sorbitol, use of broad spectrum antibiotics. We all have seen Clostridium difficile. This is a dangerous condition. MRSA, CMV enteritis, viral infection can be there. Inflammatory bowel disease can have diarrhea. Use of risk factors, these are there. Presence of infection, malnutrition, hypoalbuminic state. So what you will do? Important is what you will do. Start with a small dose and gradually increase the dose. Then see here, changing the EN formula, contain dietary fibers, hyposmotic. That should not be containing fat, lactose, or milk protein. Contains peptide as a nitrogen source. Then semi-solidification, change to EN formula, change to viscosity, adjusted, and other things. So what is refeeding syndrome? Refeeding syndrome is an anabolic reaction. It is potentially life-threatening condition associated with serum electrolytes, shifts. I am talking in detail. So phosphorus goes down. The main trigger is the switch from a catabolic to a anabolic state. When the patient is cachetic, immediately you give too much feed. So higher mortality, especially in patients with HIV and critically ill patients. So decreased blood glucose is there, so increased blood glucose, and you give too much feed, sudden increase of insulin. So there, what will be the? It will push the phosphate inside the cell. Again, abrupt decrease. So abrupt decrease serum phosphate. So what it will say? So what are the consequences? That is important. Patient can have heart failure. Patient can be hypotensive and shock, cardiac arrhythmias, electrolyte raise, diarrhea due to intestinal atrophy, delayed gastric emptying, arrhythmias, acute tubular necrosis, respiratory muscle weakness, prolonged ventilator weaning. Important, prolonged ventricular weaning. You always check for your phosphorus levels. Patient is not coming out. Hemolysis, poor platelet functions, muscle weaknesses, important one, tetany, rhabdomyolysis, seizure, coma. So all are there. These are the risk factors. Are not nice diagnostic criteria. Is not going to talk. So diagnosis, This is important. Edema, tachycardia, tachypnea. Think about refeeding syndrome. And so check potassium, phosphate, and magnesium. If serum concentration low, start correction. Phosphorus has to be corrected. 50% moderate is don't give 100% energy in first 48 hours. High risk 10 calorie per kg per day, increase slowly over 4 to 7 days. Extremely high risk or then less calorie, 5 calorie per kg per day. So COVID-19, I'm not going to talk about, I'm running out of time. So what consider nourished or malnourished? These are considered EN. We have talked about 3 to 7 days. ENs, the same things, same guidelines. So you have to target how much you slowly increase your calorie requirement. Don't immediately, you see day 125, day 250, then again you increase your protein requirements, other things we have talked in detail. So some questions are here. You are planning to start enteral nutrition. What is the daily calorie goal that you need to meet with tube feeding? How much? Anybody? Shrikant, can they answer ask them what they are writing? Ask them. Intubated sedated patient in your ICU. How much calorie need basically?
Please answer please write down your answers in the chat box, please.
Then we will answer the questions also.
Am I audible?
Yes, you are audible.
Please write down your answers in chat box. Yes. Till now, I have got only one answer.
How much is it?
Two answers. 1800, sir. 1800. Answer B. They have mentioned that two answers, and they have answered
So
B.
normally ask them how much the calorie requirement is there. How much the calorie requirement is there?
We can unmute them, sir.
Anybody?
Sir, now we can unmute them. Unmute them, sir. All are writing B. Four answers.
So one by one, we'll. What is why they are writing? What is the body weight here? At least 25 to 30. So how about 20? This one 1800 is very less. At least 25 to 30 kilocalorie per kg body weight. It will come around the right answer is 2100 kilocalorie.
If you minimum will take 25 kilocalorie per kg, it will be minimum of 2000. So 1800 will be less. So yes. So at least we give 25, and the range is 25 to 30. So 30. The appropriate answer will be 2100 kilocalorie.
Thanks.
That is somewhere between 25 to 25 to 30, sir.
So next question is, which of the following should have enteral nutrition advanced to goal within first 24 to 48 hours of hospitalization instead of waiting up to 1 week before instituting enteral nutrition? What is the right answer?
Please answer. Please write down your answer in the chat box.
Just differentiate in which of these cases we can give enteral nutrition within the first, instead of waiting up to 1 week. One answer is
someone
correct.
Yes, sir. Someone has answered.
What answer is written? See, just I'm explaining right now. We are lacking time, running sort of time. 25-year-old history of diabetes mellitus, now post multi-trauma patients. Definitely, initially giving enteral nutrition is not possible. Which organ is damaged, esophagus, other things, intestine is damaged, or there is might be, we don't know. So we cannot start within first 24 days enteral nutrition. Then the second one, ROSC means return of spontaneous circulation after cardiac arrest. Here also we cannot give. Patient may be on high vasopressor support. You cannot give your enteral nutrition. Then again, the last one, 85-year-old history of lung nodule post right lobe lobectomy surgery has been done. Immediately, you don't give enteral nutrition. Lobectomy, you give parenteral initially. The big surgery is a major surgery. In this only, C, COPD with hypertension with urosepsis renal failure, you can think of giving enteral nutrition. Anyone? Differing?
Someone has answered A, sir.
So I have explained to them. We are running
Yes.
short of time. Frail appearing 82-year-old male is admitted to the ICU with respiratory insufficiency due to pneumonia. A nasogastric tube is placed as there are concerns for dysphagia and tube feeds are started. Approximately 24 hours after the admission, a patient develops signs symptoms of left heart failure. And the most likely cause for this patient, sudden cardiac dysfunction, we have recently discussed, isn't it?
Yes, sir. Yes, sir.
So
Can one identify the diagnosis?
Frail.
Identify the diagnosis?
Insufficiency. Anyone?
Can someone write down the diagnosis instead of giving an answer A, B, C, D? Can anyone identify the diagnosis? Why this patient developed LV dysfunction, cardiac failure? Basically, this is a complication of starting nutrition.
This is refeeding syndrome. So basically, low phosphorus. We have discussed that your call pulmonary everything, heart failure, complication of low phosphorus, arrhythmia, other things can happen. So next question is, long periods of parenteral nutrition are not recommended because of, this is simple one. It increases toxicity of the blood. It puts pressure on the kidney. It puts pressure on the heart. It causes the GI tract to degenerate. It's a simple one. Why use? Why we want to give enteral? Yeah, they have answered? No.
Not answered, sir. No one has answered it.
So basically, it causes the GI tract to degenerate. It prevents, enteral nutrition prevents from GI tract to degenerate. That's why for prolonged use cannot be given.
Someone has answered correctly.
D.
Two answers.
D. Great.
Sir. Yes, sir. D.
D. Great. Good. Congratulations. So the percentage of total caloric output from carbohydrates should be between this simple one.
Again, simple question.
Simple question. Very simple question.
Please write down your answers in chat box.
What they have answered?
Two A. The answer A. And A is a wrong answer.
Wrong answer. Around 50 to 50%.
A is a wrong answer.
50% to 60% you will give.
Most of the energy, yes. Most of the energy are derived from the carbohydrates.
So next one, the last one, patient calculated nitrogen balance is 4 grams per day. What changes to the patient nutrition would you make? Increase protein intake, decrease protein intake, no change need to be made to the protein content, begin 25% albumin every 8 hours. This is a difficult one, unless until you know the normal nitrogen balance per day.
Yes, sir.
They have given you.
To answer this question, you have to know the basics, very basics.
Very basics.
Then please try to answer this one. One answer. A. Someone has answered A, but someone has answered B. Again D.
So I'm interrupting just the normal nitrogen balance. I'm not going to detail 4 to 6 grams per day. So there should be, in all balance is 4 grams. So no need to change to the protein content. So this was the last question, I think so. So Shrikant, if you like to add anything, and if you like to say something or answer their questions, anything, you can do.
Yes, sir. Sir, this was a very interesting presentation, sir. You have talked about each and every aspects of the nutrition in critical ill patients, starting from the how to start nutrition, basic pathophysiology, how to start nutrition, which nutrition, enteral, parenteral nutrition, all guidelines, also each and every organ and disease specific nutrition plan. So this was a very indeed comprehensive as well as detailed and lucid presentation. Just as there is no question, in the chat box. Someone was uh, Sweetie was raising her hand, so trying to ask something. Can you please write down your question in the chat box, or you can unmute yourself and speak? Hello, am I audible?
Yeah, you are audible.
Okay, sir, there is no response. Yes, sir, there is something in chat box. They can't unmute, sir.
Okay, chat box, what
Okay,
they have written?
so no, sir, this is from our host,
Okay. So any
coordinator.
questions they
This
have
is
written? No.
no question in the chat box, sir. Sir, just to summarize,
Yeah.
just in a simple manner, for I am asking some silly questions on behalf of them. So, when any new patients comes to our ICU, how to start the nutrition? I mean, which what should be in the simple way? What should be the
First
nutrition plan? That means,
important, first
yes, sir.
important thing is we have to just categorize what nutritional status is, whether he is
Yes, sir.
cachectic, what disease is having. Suppose we have to also categorize the CKD, CLD, other things, or patient is having malignancy, or patient is having COPD, important thing. And suppose any acute illness is there. Anyway, in any cases, if the patient can tolerate, we have to give enteral nutrition. First, orally, if patient can tolerate, cannot tolerate, we will start with whether acute pancreatitis, NG, or nasogastric, not tolerate, the patient having a chance of respiration, we'll put whether nasoduodenal or nasojejunal we can put. If the patient is also not tolerating, having not meeting calorie requirement, then we have to go for the parenteral, or if the patient is post-surgical cases and any other things, definitely immediately we cannot give enteral, then those cases parenteral. But again, we have to come back to your enteral, and later on the everything okay to the oral. So accordingly, first start with the low hypocaloric. Start with the 25, 30%, 50% of the caloric demand is there. You start with the low doses, then gradually increase doses. You see whether the patient tolerates or not. That is very, very important. And accordingly, you give adequate protein. Protein intake should be good. Around when the patient is CRRT and other things, around 2.5 gram per kg. Otherwise, in normal signal function, 1.5 to 2 gram per kg. Even the CLD patients, 1.5 gram per kg body weight, you have to give protein. Don't forget to give your balance your, and accordingly, what I have talked about, branches, chain amino acid, other things, another your glutamine, especially no to glutamine. Don't give glutamine if your MR comes and you give glutamine. No. You check CLD, CKD, no to glutamine. Multi-organ failure, no to glutamine. Your transient this traumatic brain injury, you can give glutamine, other things. Very, very few indications. And antioxidants you can give in every patient. That is good. But again, you have to see if that LCD or MCD, what you have to give accordingly, you have to properly see that. This is my basic.
Thank you, sir, for explaining everything in yourself. Just I think I can say just to summarize, as Sir had detailed everything and each aspect of the nutrition, I can say only a few words. Just start nutrition as soon as possible. Your first route of choice for nutrition is enteral feed, unless whether the patient is taking orally. Your first route of choice is enteral, and give adequate protein as well as calorie, and always start with hypocaloric diet as sir said, and gradually increase your protein and calorie intake, and your calculator or required protein or calorie requirement must be optimized or fulfilled by the day 3 or 4. And if you are not able to achieve your enteral nutrition, you may have to optimize the enteral nutrition by adding some prokinetics, or if in spite of doing everything possible for optimizing your enteral nutrition, still if you are not able to achieve your nutrition goal, you can go for supplemental parental nutrition or total parental nutrition, as sir has detailed in his presentation. So one more thing, when you start nutrition or give nutrition, as sir has detailed, you also have to take care of the troubleshooting part of the nutrition. As sir has detailed mentioned in his presentation about refeeding syndrome, it is not a very uncommon manifestation, because in Indian scenario, most of our patients are undernutrited or malnutrition. When we receive the patients in ICU, most of our patients are malnutrited or undernutrition. when we, in order to achieve our target protein and calorie intake, when we boost them with the nutrition, that protein or calorie, these patients go into refeeding syndrome. So you have to also take care of the refeeding syndrome and all the troubleshooting part of the nutrition. I think sir has mentioned each and everything. And anything,
And then
sir, you
lastly,
want to add?
I'll add, when the patient is having diarrhea, you can change your fat content, that milk protein content, and especially don't forget about the long use of antibiotics. You can stop your antibiotics and the Clostridium difficile, the offending agent, the other things. Even the viral diarrhea, it could be CMV, other things. We think about stop even the diarrhea is continuing. So keep your mind open, and especially the feed. So these things can change your ICU practices. That's all what I want to say. So we can end here now.
I think, sir, we have reached the time. We can conclude here.
Thanks,
Any
Dr.
questions from
Ranveer.
anyone?
Thanks, Dr. Shrikant, and everything for great moderation and other things. Any questions? No?
No more questions, sir, in chat box.
So we can stop here.
Thank you, sir, for a nice presentation. Thank you, ICCM, for this opportunity. And thank you, all our participants, for participating in this and spending their valuable time for hearing this lecture. Thank you all.
Thank you.
Thank you, sir.
Thank you.
Thank you
Thank
very
you.
much.